So we are there, my friends. Good evening, all across the world. We're going to talk today something very, very relevant, which I told, which is relevant for the times and for times to come. This is about vertebral augmentation, and we're going to talk something very, very different and novel, which is the expanded indications by improvisation of our techniques. So you're going to see a good number of patients which are otherwise impossible to manage and handle, where we are doing vertebral augmentation with very good success rate and a lasting result. We're going to talk something in burst fractures. We're going to talk something about vertebral plana. We're going to talk something where there's multiple fractures in given patient, or with the retroposition with cord compression, and how we circumvent that problem. I've been delivering these lectures internationally, and this was my talk for last 2 years in the New York Global Congress, which is the annual congress there, and it was very well applauded there. So there's no conflict of interest except that I want to heal thy pain, and thus patients are suffering, and no, pain is as old as mankind. Yes, it's still very, very mysterious, and we know it becomes all the more troubling in these scenarios when you have a chronic pain, which is to do with osteoporotic fractures. Yes, under treatment of pain is a pandemic problem, and it's cruel to deny a right treatment. And here is the right treatment for these patients. So, and with all this interventional pain management and other techniques, which are advanced techniques, we can really pull many patients just with interventions than when more bigger operative things, which is our intent today. Let's see how best we can help them. There are patients who are suffering in pain, they're inviting death and say, what a pain. And then there is agony all over. And then you do a right treatment for these patients, and suddenly they are back to life, and they start saying, what is pain? So this is about, and we understand, we at the Western world and the Eastern world, there is increased expectancy, and we see people living about 100 years. It's not unusual. But obviously, when you live longer, you're going to have some problems. And osteoporotic fractures or osteoporosis is one of those problems, which is very, very rampant, and you have to address it. Otherwise, it becomes a very big liability. The assets society become liability. Understanding one real fact is that fragility fractures are mechanical consequence of a biological disease. Then, then you have to treat the biological disease, which is osteoporosis, and we have to treat it very, very aggressively, especially in the event that we are doing. If a patient comes to me with a fracture, I know has already got a problem. I have to treat the fracture and as well as the generalized disease, which is osteoporosis. So there are very good medications available these days, advanced medications with teriparatide, denosumab, bisphosphonates, D and calcium and other things along with lifestyle changes. And you have to treat it because you want to avert future fractures. The whole idea is, if somebody has got a one fracture which is osteoporotic, chances of having second fracture is 5 times. If somebody has got two osteoporotic fractures by any chance, chances of another fracture is almost 85 times. So you have to avoid those fractures which may come later on. And we know the long consequences of a osteoporotic vertebral fracture, especially in senile age group. There are so many things which crop in, and there is increased age-related mortality in these patients. So what you have to do is you have to take them at right time, treat them right, and you have to bring it back to normal. And that's what you are trying to avoid, all this consequence of this spiral. We know if we don't act in time, they tend to collapse and keep collapsing. We have a wishful thinking they might cure by themselves, but it does not always happen. Here is a patient who has got a collapsed vertebra here, and he was putting in a cement was troublesome in 2007. Now I do these kind of fractures also, which I'm going to talk today with my novel techniques. Another thing is, if somebody's got a one level fracture, if you don't deal it well, there are chances having another fracture becomes higher, which I told you. So you keep seeing these multiple fractures. Patient had one fracture, didn't go for it. Look at this. The second fracture comes up, and now one has to really think seriously that this has to be corrected. Otherwise, having another fracture is very high. Look at the flexural deformity, which is already cropped in, set in there. So there's going to be higher load on this and this vertebra, and going to be adjacent level fractures, and you have to treat them. Look at this patient. Got a multiple level fractures, one here and one above. And look at the flexural load which was there, the kyphotic deformity which has come in, and patients lying prone on a table when I'm trying to do a procedure. This is D8 level. And it's totally collapsed, kyphotic deformity, and patient has got a back pain, muscle pain, and postural pain along with that. And you have to treat these patients. And this is one patient where I did a D8, D11 fracture, both I cemented with my new technique. I had a patient who is 79 years, this lady, who used to come every year with a new fracture. I cemented her 10 times. So this is not unusual that you get 10 different time fractures, but there are patients who got 6 same time fractures also. I'm going to show a few of them today to you. Now, she came another time with a new pain and she said, I've got another level fracture. And I just did a bone scan. I found it to be a rib fracture at the rib costotransverse junction fracture. So you do a paravertebral block or costotransverse block here, and the pain is taken care of. If you don't treat them in time, they keep taking painkillers, they have their kidney gone, and dialysis units are full of these analgesic nephropathies, and they have a GI bleeds, especially older age, and then you have a narcotics, then you have a CNS symptoms they crop in. So they all are not great things to do, especially for the want of a pain relief, which is very easily attainable with one simple needle and cementing. Now there are remedies are there, like all these tailor braces or dorsal lumbar braces are there, which are there since Egyptian times or Roman times, but they are not always productive as far as pain relief is concerned. Although we try to give them in patients, subset of patients which can heal by themselves with medical management. Obviously, then it's all the more important. If you don't give them brace, they're going to collapse all the more further before the healing happens. So it's important to give them braces. But once you cement, the braces are gone then. Now, the cementing is done basically for strengthening in osteoporotic fractures. This is here. But it is done in cases of hemangiomas, it is done in cases of neoplasms, and sometime in real traumatic road traffic accidents or fall fractures also. Although the osteoporotic fractures all have a travel trauma history, they're not really traumatic fractures. They have a osteoporotic setting and then they're fractures. So these are the patients. We know the indications, senile osteoporosis. It scores over all other kind of fractures. We have a metastatic fractures with this aging population. We are seeing so many. I'm seeing so many of these metastatic fractures, and I've got a few of them today for you. And then hemangioma, aggressive hemangiomas. And by the way, it was discovered in one of the cervical aggressive hemangiomas in France in 1987. And thereafter, then it has been treated. Thereafter onwards, it's been almost 30 years, and people are getting treatment done. And we do it even in for strengthening of the vertebral body for a major surgical procedure. Otherwise, screws they don't purchase well and they come out. So that's where it is vital, and we have a cemented screws for that matter. This is what I was saying. Aggressive vertebral meningioma sometimes can be painful in lumbar area, but mostly in cervical area. And there you try to kind of cement them, or basically sec embolization of the hemangioma, which is routinely done for other techniques by interventional radiologists. Here you can do it with a needle and cement embolization. A steroid dependent patient, a patient you can imagine 1, 2, 3, 4 level fractures. You start at 5 level and then you start counting from 5, 6, 7, 8, 9. So we keep seeing these fractures coming, especially patients are totally steroid dependent, like arthritis patients, and they fracture, and then you have to help them for the pain part because they can't take too much of painkiller too. And fractures, they don't heal in such subset of population. I have got a patient for cementing as a osteoporotic fracture, collapse fracture. I got a fresh scan done in my hospital, and you look at the lesion there. There's one lesion up there, one lesion there. It came out to be a metastatic fracture. So must know if it is metastatic fractures. Treat it in a different oncological way instead of doing it. And we know it's the commonest mats are there in the vertebral bodies. We know the 33 vertebrae there, and we keep seeing. And the lumbar ones, when there's load sharing is there, they are the one which causes pain sometime. You might have to cement them. But before you cement them, must do a bone scan. Find out if it's by any chance infective or metastatic or just a traumatic one. Know it for sure. Do a biopsy, scans, colored scans, everything, and then you go ahead with your treatment. Because if it come out to be infective, you're not going to cement it. If it come out to be a neoplastic, you're going to send for oncological start of care first, and then if it is osteoporotic, then you take up in your own scenario, on your department, and start treating them. We know L1 fracture being a dorsal lumbar area of transitioning, there is a most fracture load is there, and that's where the most fractures are there. L1 is the one which is maximum than the D12. Others may also get fracture L2, 3, 4. They're more on the eye trauma or weight bearing. And then these ones are easy to cement because wide pedicle, big bone volume, you can cement them well. Again, cementing L1, D12 is not as bad because they're morphologically they're as good as lumbar vertebra. But then you have to have a right technique when you start going towards dorsal area. I have done till T3. Somebody was asking question, what upper level you've done? I've done cervical also. There are some contraindications. But frankly speaking, there is contraindication shrinking, and they are turning into a relative indications like destruction of the posterior spinal element, which is obviously a surgical scenario. But if it's posterior cortex, I do treat them cementing way. Burst fractures, I do cement them. Neurological compromise is there. If it's early one, reversible, we can cement them and do the correction, final correction. But it's already delayed one, then obviously it becomes a surgical decompression and fixation part. Then the vertebra plana, I do cement them. I told you infections, you no, straight no. If you're allergic to dye, obviously no coagulopathy, correct coagulopathy and treat them, no problem. And then you have the medical comorbidities. Although cementing is more benign procedure in good hands, and it can very well be done. X-ray alone is not enough. Sometimes we just do an X-ray, find this to be fractured, but you get an MRI, you find this is not the one which is paining, this is the one which is paining, and you can't cement this one. You got to cement this one. A patient who had a fracture here, and and came out after some time, and we found like another patient, like this was the one which looked to be fractured on the X-ray, but look which is causing pain is this one. So MRI is a must, and fresh MRI is a must. Sometime you might have to do a stir sequences, contrast MRIs, and I told you bone scans to really know which is old and fresh fractures, and treat the one in their own right. I've treated fresh fractures with 5-year-old fractures also. The point is, know what is right, where is the bone edema, there's the continued weakening of the bone. There you can go and cement it. For sports structuring, I do a vertebral reconstruction also sometime with these procedures. I told you, this was a patient who came to me for cementing 20-25 days on, and this was what it turned out to be. When you're doing fracture cementing for this and this is entirely different ball game. Know the facts and treat accordingly. And I always say, if patients travel distance, I always want a fresh MRI to be done at my place because I don't know what has happened in the meantime. Another patient, and he was not treated by any doctor like for intervention or surgery, and he had a problem, but he came late recently to me, and look what has happened. It's totally compressed, compromised, canal stenosis severe. I said, go for surgical decompression now. Patient still thinking. So this is the worst thing. The surgery phobia is so much so that really bothers. But yes, there are reasons that time. Sometimes you do a good fixation, but look at the rods are broken here, and again the flexion has set in. So there are some cases where you, in spite of good surgery, sometimes there are problems. Like this patient could have been very, very well cemented, didn't go for cementing, and he had a collapse in 2 months, 18 days exact. And he was one of my old patients, 64-year only, diabetic and alcoholic, total collapse. And at D10, D11 level was a fracture. So thoracolumbar surgery was done, and vertebrectomy, titanium caging, and everything was done. He had a hemothorax, treated hemothorax. He was discharged from hospital to be brought back dead 2 weeks after discharge, a week after discharge. So these are some sad scenarios which hurt you inside, deep inside, that you do right thing at right time. That's why we should change as per patient changing needs. And these are the times with the aging population, with our own years and years suffering, we should do something about them. There are complications with any procedure, and you have a learning curve. These all lectures, what we're talking today, they really help the learning part of it and shorten your learning curve also. I'm going to today share many difficult scenarios and how to avoid complications, and that will be very, very helpful for many of my friends. Choose your patient rightly. Somebody did a cementing on this patient. Look at this patient. Cement has been done. Retropulse fragment is there. Both pedicles are ruptured. Still, you can see pedicle distance is there. Patient is not able to sit at all. This is no good. Do the right thing, because these patients can't be helped sometime with just cementing only. Another patient had a fracture. Somebody has done a good cementing, but a good retropulsion of the vertebral body. So a cord compression sets in. Somebody has decompressed this level with screw fixation and surgery, and you can see laminectomy, but somebody is compressed in here. So that patient is symptomatic because of this now. So one has to be careful with the cementing part. Another such patient, a cementing done, and look at the cement lying all over in the canal. Now you have to decompress it. You have to open it. Urgent on-table procedure. It's a nightmare for any interventionist or a surgeon for that matter. Another patient, a good work done, multi-level cementing. Look, the cement is lying in the epidural canal. This is the vertebral posterior margin, and it's lying in the epidural canal. Patients having symptom. pain, and he's still able to walk. I'm surprised. And then I had to do a spinal cord simulator in such patients for pain relief. Although patient was planned for another surgery or another redo, total revamp of the surgery. Another patient very recently came to me a week back only. A good work done. Look at the cement, look as if it's in the canal, but it's not in the canal. It's going sidewise by the side of the intercostal nerves and in neural phenomena. Patient is symptomatic because of intercostal neuralgia. You go and treat this easy. Perivertebral block or intercostal block is treatable. I was sent for perivertebral block. There may be scenarios that you might have to do a chronic pain scenario for these patients, the DRG irritation. You might do a DRG stimulation techniques, neuromodulation. So much is coming, so much is happening lately, and we can do help such patients, which was not possible earlier. So, what are the best routes? Now, I'm going to talk about the technique part. The best route in cervical is the anterior, like we do discography. In dorsal area, thoracolumbar area, or dorsal area, we do transfer junction or parapedicular, you call it. And in lumbar area, is typically transpedicular. And this is the cross section of the or cadaver morphology of the bone, cadaver bone, that where we try to go in. We go from the pedicle without breaching the medial border of the pedicle, go anterior most possible, and start injecting cement in there. Don't you worry if cement comes in the basivertebral vein, comes and shows up here. We should be sure it's just a basivertebral vein, not the fracture crevasse where the cement is leaking. So this is to be understood, and it can be very well done under local. People have a choice of anesthesia or other thing, but I prefer local because patient feedback is there, and I don't need higher anesthesia for such patient. Some points for OT preparation: keep OT cool. That's most important because the cement is best when it is cooled down. And then keep your cement and liquids in the refrigerator and keep it cool temperature wise. And then we have a typical biplanar. If it is available, nothing to beat it, by the way. If you have biplanar fluoroscopy, you can really save on time, but it's not available all places. I've seen in Hopkins, and but still we do AP lateral. It is still time consuming, but still is doable. Now the target point is we go from the superior outer pedicle, right from starting from here, outer cortex, and go inside in the vertebral body without breaching the medial border of the pedicle because your nerve is going next to this. So this is to be understood. Be it this one. You start from here, you don't breach medial border because your spinal canal starts there. Look for the reference. This is the pedicle. We are not supposed to breach the medial border of the pedicle because root is there, spinal canal is there, and cement leaks in then once you're trying to inject cement. So this is to be understood. Once you understand this philosophy, it's a very good, very safe, and very much doable procedure in even in dirty fractures. And that's what the oblique view is. Scotty dog view. Start from there, upper outer quadrant, keep going inside. Don't breach medially unless you're well inside vertebral margin, posterior vertebral cortex. And then you are the king. You can move anywhere. You can navigate inside the vertebral body. But the whole idea is try to be as parallel to the pedicle as possible. But on the same time, be as parallel to the vertebral body as possible. Sometime by intention, you go towards the fracture or go away from the fracture. If it's severe osteoporotic fracture with a lot of cavitation, I stay away from the fracture dehiscence because then schema starts leaking there. So I stay away, start feeling the whole body first, then comes last at the dehiscence, depending on fracture cavitation. But when we have angulated pedicles, we have to go calculated. I'll show you one of those patients who had a vertebral plana. Look at this. This is the total width of the vertebral body here. You see, this is disc, and we are trying to fill in the cement there. So you don't oblige the pedicle then. You oblige the vertebral body then. You go in the vertebral body and will do a good cementing, fill the cement and come out. Although it can very well be done with the navigation techniques we have these days, all those computerized navigation there, they can be at your help if you have them. Wonderful. There are some angle needles which you can go and put inside and do your angulation, do 360 rotation and keep injecting cement inside. Same you can do with the bevel also. Needle bevel also very helpful for cementing. There is a one technique. If you have a collapse here, end plate collapse, you can put a hook inside, endoscopic hook inside, and elevate the end plate with the hook and then put cement inside. It is doable. Technique wise, start from the upper outer quadrant in this AP view, and this is the lateral view. Like X matches with the X, green, red, pink, the yellow with yellow, and the red with red. So the whole idea is the green keep going, the blue, the yellow is you got cautious now, And as soon as you reach the red, you got to stop, find AP and lateral both views, and you should not touch this red until unless you've gone at the posterior margin. I told you. Thereafter, they're not worried about the leakages. It's like here. You're starting from here, you're not reaching this border until it's well inside. Same thing here. Whether you have to do unipedicular or bipedicular, this will depend what is the fracture morphology, which level the fracture is, or is dorsal or lumbar one, what is the pedicle direction there, what is the pedicle width there, can you negotiate with a single needle across, or these all factors they count. I these days try to do a single needle technique. I try to be more oblique, feel the things first and come out. Why it happened? It used to happen, I used to put two needles first and then start injecting first needle there. Then I used to find some patients when I'm putting needle through the first needle, it starts with something unfilled. I put my second needle in there and do the rest of the cementing. This is what you are understanding. This is when you're doing two needle technique, you go more vertical or more straight. And if you want to do single technique, you go more oblique and don't breach the medial border because spinal canal is there, and do your work. Same picture is clear with the before you reach in here, you should be right in there in the posterior cortex. And once you reach in there with single needle technique, I told you, before I reach the anterior margin, look, I'm already across. So it's going more oblique, going across. That's the whole idea. Across is, remember, this is the other side. You have the vertebral body. You don't want to remember the vertebral body is round. So if you go across, you might breach the other side. And I'll explain you after some time. Like if I'm going from here, let me explain in here in this image. I start from here. I'm right there. At this point in AP view, I'm still behind this margin. And in the lateral view, I'm sorry, in lateral view, I'm still behind margin. In AP view, I'm still medial to the medial border of the lateral border of the vertebral body. The whole idea is because it's roundish, but still it can breach in there. Suppose I'm there. In both ways, it looks great for AP lateral, but I'm already outside. So this has to be kept in mind that you're in a roundish body where you're trying to go across. You should be careful. If you go across, your semen is going to leak straight. And the dorsal vertebra, they're more straight in the pedicle wise. And when trying to go in there, you have to do with the bipedicular approach, number one, because you can't go across and you don't want to breathe this. And you try to go costotransverse mostly in such cases. So that is helpful. And that sometimes I even the lower dorsal vertebra, I can manage a single needle technique. I have devised one more technique is I put a K-wire first. And sometimes I drill the K-wire instead of hammering it. And over the K-wire, I put my vertebroplasty needle in, which could be a metal needle or any other needle. So I said, please don't hammer. And that's the whole, which I presented in the Sydney World Congress in 2005. Initial, my few cases was a traumatic fractures, which was not done before that. So now people are doing in traumatic scenarios also. And then over the K-wire, ride your needle in there, go to the anterior cortex, and there you're certain in AP lateral view, start putting your cement in there. And this is, you see the scenario. K-wire first, and then the needle over the K-wire. Why? Because sometimes the pedicles are very narrow, and costotarsal junction is, you're hurting in any case, you're breaching it. And sometimes you're breaching the rib head also. You don't want to poke it again and again if you're not in an accurate spot. With K-wire, you can be accurate first, and then you put your thicker needle over this, and that saves on the trauma. Be careful. You are never going to go anterior to the vertebral margin because your major viscous structures there, be it lung, heart, aorta, vessels, they're right there. So that one has to be very conscious of. And you can just jolly well, this is a patient who is a doctor, and I did 2 level of cementing, and look at the global fill at the D5, D6. It's very, very satisfying. Sometimes you have to do multiple level fractures, like there are 5 levels of fracture in this patient, or 6 level for that matter, and you're seeing 5 needles in place. You don't put 2 needles together from one side because they start fighting, like these 2 needles are fighting over each other. So cementing becomes difficult in such scenarios. And when you have multiple fractures, please aspirate the bone marrow, because the whole idea was not doing more than 3 initially, was that you once start putting cement in, your bone marrow starts getting into the central circulation, and there used to be bone marrow pulmonary embolization, which can be symptomatic in a compromised patient. So you aspirate the bone marrow, and yes, then you start putting the cement in there. And I told you earlier, once you start putting your cement in there, sometime it may show up with the base vertebral vein, And that is where you suppose your cement is here, you're trying to put in here, it may come back in there. And with experience, you understand it's a basivertebral vein or something. If it goes into the vein for the matter, any vein, or it's going ahead like this, any other vein or sidewise, you know it's a venous leak there. What you do is you wait for a few seconds to a minute. Your this cement which inside body is a 37 degrees heated now, it hardens very fast. So it kind of fixes, it becomes a thrombus right there inside the vein, and you have a cement thrombus. It doesn't allow any more cement to be regurgitating or coming backwards. So then you can start injecting, change your bevel direction, start injecting. Some people used to do a venography. Now it's a choice, just to you want to be sure. But if there's one hindsight is, when doing venography, you're putting your dye in, your bone becomes all black. Now how will you see your cement coming in now? So it's a very, very tricky situation, catch 11 situation. So what you do in such scenario is that you kind of, even if you have done this, you found you are in a good place and there is bone is already black, what you do is you wash the dye with the saline, and you again make your bone look as transparent as other bones, and then you start injecting cement there. This is a trick you can use of. And cement, if it is a big leak and you're not very careful on it, can, people have done a pulmonary embolism, there has been one death also. So one has to be careful. Somebody is, a big cement needle is lying inside the heart also, and in lungs in some patients. Mostly it is not of any consequence, but rarely it can be significant. So please, you don't want to have any complication with such a good procedure. So it's only the complacency which kills the patient. So, and obviously, and your morale also. So you do a right job in a right spirit. Well, there are end plate dehiscences. You try to put cement in there, it starts leaking one way or the other. I don't mind cement going all 5 walls, be it upper, lower, all 3 side walls. I mind only cement coming into the spinal canal. That's the reason. And when you have a cement coming in these ways, you wait, let it get cemented, harden, and then if your needle gets choked sometime, which people who are doing it, they know it. What you do is you put in a K-wire, if you can put in a K-wire through needle, and change your needle. If you can't put a K-wire through this, you just take the first needle out, maintain the same image through and through in a Scotty dog view, and using the orifice through which it is gone, and then you put your needle through same place again, match the images, and then you start taking your further work on. So changing a needle is required sometime when your needle gets choked or there's some issue. Well, in a malignant fractures, if it is osteolytic fracture, very good, put cement in there, patient's happy, you're happy, and I do it very often. But if it's osteoplastic fracture and you're trying to put cement in there, and it will push the tumor mass towards the canal. So it's always good to kind of first take care of the tumor mass, do a radiofrequency ablation, I do plasma, and you debulking, tumor debulking, and then you start putting your cement in there. And you do it only till you want to reinforce. It's a palliative procedure. In those scenarios, you just reinforce so that pain is taken care of. Well, people have done mistakes, and humans do make mistakes. The semen is lying in the canal. Now it is going to be symptomatic. Another such patient is lying in the canal. It can be or may not be symptomatic depending on which level you are. And if that is the case, now there is a very good technique. One can endoscopically remove these semen. People have done it. So please, people who are surgeons, they know what it means. Paraplegia is a known complication. There are so many other complications, which I told you. This is one is percutaneous endoscopic decompression and vertebroplasty. And same way you can remove the cement also. And it has to be instant decision, on table decision. There are so many reports of a vena cava or vascular or into the other spaces, or retroperitoneal cementing or cord compressions. One has to be careful, I tell you. It's a liquid after all, fluid state. And there have been papers in where all it's normally it doesn't leak much. Even if it leaks, it's mostly inconsequential. I told you, the 5 walls I'm not worried, only spinal canal I'm worried, or big venous embolization which is going into center circulation, then is a worry. Otherwise it's a very, very safe procedure with a very good results and a lot of benefit to the patient. There have been good number of studies which tells it's asymptomatic mostly. Rarely it can be symptomatic, but still if you're good, you're conscious, you don't let it happen. There can be some root irritations, which I showed you one patient. You do a local steroid injections. If at all I have to do intercostal, I can even do RF or a neurolytic block there. How to avoid these complications of cement? Make cement very, very visible. So either you have a high visibility cement there, or lately I'm doing something which I show you, which is my innovation. And other thing is, know the cement timings. Very, very vital. Your stop clock starts as you start making cement in there. Was a mixing time or dough time and was a working time. You don't get a pressure, time pressure on you, because if you start doing work against time pressure, that's where the most cement leaks happen. This is what I was saying when I'm making cement in the cold saline. So your temperature part is taken care. More colder your cement is, more liquid it states, more times it stays liquid and gives you more time, working time. And number two is, once I'm making my cement in there, I'm putting the radiopaque dye. I presented in the World Congress in New York also. I radiopaque dye and my cement is so visible there. Each drop of cement, even if it goes into some vein, small vein, I can see. And your cement is nicely seen. You can see a small particle cement in there, small particle cement there, which sometimes I leave by intention if I think particle is weak. Otherwise, you can see a global fill. So this is visible only when you have a cement opacification. Well, there are some cement types. The PMA cement is bad because sometimes it doesn't indigitate well, although the other cements are there which interdigitate, and it's very, very important to interdigitate. I'll explain you. These are some bone types. The PMA is the one we've been using. Then we have a other composite cements and calcium phosphate cements, which is more recommended these days because it's a highly biocompatible. It's a very radiopaque, and then curing temperature, it doesn't get heat very fast or heat too much, so there's no toxicity. The cost is little high, is deterrent sometime, but it's bioabsorbable. So by the time fracture heals, the cement absorbs. That's what calcium phosphate cement beauty is. It takes the shape of it. It is matching the bone molecular biology, and that's where. And then so many types of combinations available these days. One has to really Google around, find which is the right cement for a given patient. And you have all big companies have come with the cement. It's a big business now, and they are helping the patient. It's a business, but still they're helping the patient in their own way. And there are so many cements available. Yes, there is help at hand. You have all these injection devices which is there, and you can mix the cement. The cement mixture and cement injectors are there. It's a choice. You want to use them, they're different cost wise in India, and some places Western world doesn't matter. It's all industry driven. But here we rarely use it. We say help at hand, or the hand at help, and that's where we do hand at help. We use smaller volume 2 ml Lulox syringes, and right under live fluoroscopic view we inject them with small volumes and keep titrating epilateral views and keep injecting. And before it is shows up with the posterior cortex, that's where you have to be very, very cautious up to posterior one third. It's said you can start injecting here until it's come vesicular vein, and at posterior one third start getting cautious, start injecting lower volume, be very careful. It may suddenly pop out where it has to be careful. When somebody said about volume, it is depends on fracture morphology, osteoporotic cavitation. So you don't fix your mind beforehand. But yes, in your idea, you have an idea how much it is going. But I call it, I see radiologically with a good cement filling, and I'm seeing it each drop of cement going in. If it is going in the vertebral margins, I don't mind. Never ever overfill. A underfill is still okay, and overfill is bad because one, it leaks. Number two, it makes the bone very hard, so the chances of other level fractures gets higher. You should be an adequate fill is there, optimum fill is there, so you don't leave the cavity, you don't leave the fracture areas there, which collapses further on and patient keeps having pain. So that is to be titrated. Use viscous cement if possible, and because it leaks less. And then you stop at posterior one third, which I said, and it may go into the disc. You are not supposed to worry, except you wait, let the holes, let the defect he seal by itself with the cement, and then you start giving further. There are chances that cement may slip away. It has happened earlier. The whole idea of the smartness game is that interdigitate all cement we are putting in, don't put in one block, one place, interdigitate in fracture cavitation or with the bones in here. So it just don't need an end block. That was where the problem was with the initial vessel plasties, that used to pop away, like a glass ball. And that's it. The OT setup is vital in here. Look at one very important finding in here. I do the cement in two things: in extension, spine extension, so that reduces the anterior load, and traction to make the cavitation further in. And then I start injecting my cement in there and keep looking at there. Look, if you get a high restoration, you can do a preoperative X-ray also, but sometimes it is not very, kind of safe. So one has to be careful. But this is what you can do is you can do flexion section X-rays. You see there is a cavitation, and you have this, and then you put your balloon in there, open up the vertebra, put cement in again, interdigitate. Don't put in a one block, one spot, and that's important so that it doesn't slip away. And you have a height restoration, and that can be done, which I told you, with the extension and the traction. One important thing, a very good job can be wasted, truly, if you've done a good job and you just take your needle out without realizing. If we remove too early, then your semen leaks out, from here, from the hole. If you remove too late and you're not very conscious that the semen is getting hardened in your needle, and it's getting hardened here, it's become one single unit. You take your needle out and you have those two semen nails looking at you, one or two semen nails. It becomes very nasty, and it spoils the mood. Where very good cementing is done, and then at the end, a complacency. It's like an accident. And what I always do is, as soon as I come out the vertebral body, I make my needle rotate in here. I toggle my needle in here, so that this cement which is inside the body and cement inside needle is not in single plane or single line. And then I take my needle out, so this area is clear. So this is something, the tail. I've had it few times, especially after a very good vertebroplasty. In a mood of cheer, you remove the needle and then you find this. It's a real quick fix thing. You put your needle in, cement it, same day procedure. Patient fell same morning, same evening. I put cement needle in there. Next day, patient goes home, and and next week, patient is back to work. This is beauty, especially in this age of a lot of demand, social demand, of old people keeping themselves fit, because your families are getting more and more nuclear, less backup now, or social backup now. So it's all the more important. And many times this is the demand. There's nobody to take care. I want to be fit by oneself. You want to be fit, and all the more reason now. Now, this lady in a polytrauma setting, she had a fracture humerus. When we're doing the procedure, we found she's got a back pain, and we got an MRI done. She had a burst fracture. This is 2006, by the way, burst fracture. And I cemented this. You can see the burst fracture, posterior cortical dehiscence, retropulsion, everything is there, which is there in the book as a contraindication. And I did my cementing nicely well inside. Look at the nice seahorse, which is holding the retropulse fragment also. And patient was sitting very next day. There's me in those times, 2006. And she had a very bad fracture humerus road traffic accident, and that she suffered for a long time, and fractures taken care in one go, in 1 hour time. One important thing I want to give a lead to my friends. This patient, I was called in ICU setting. Patient is in ICU on ventilator. I said, what's the problem? He says, patient had a back pain and he had into severe bronchospasm. Patient already had a respiratory disease, and patient was put on ventilator. Once I was out of ventilator, they told me he's got a fractured spine, and it is known now the fractured spine or pain of the fractured spine can sometimes be the inciting reason for the severe bronchospasm, and sometimes even MI and other things. So one really has to understand, especially older age, that you do. I did a cementing this patient, and you see the patient is back to life, and he is diabetic, by the way, diabetic retinopathy. He was kind of blind. Sixth level, which I told you, this was a patient who had a one nice rosy looking fracture, which was not even too much of fracture, and managed conservatively. 2 months, 18 days to be exact. He developed 6 level fractures from single level fracture. And this was the original fracture. Can you imagine? Others are new fractures. And patient was in a big pain. Nobody realized. He fell a few times also in between. And he was only 59 age. A little diabetic and little colic, but still this all came up. And I got an X-ray done and found that there is a new fracture on X-ray. This was evident. I got an MRI 6 level. I did 6 level cementing in one go in 2010. This is a long back. And look, there is a flexion deformity is taken care of. There's no leak of the cement, a drop even in the spinal canal. And that is how. The technique is you do 2-3 levels in one go. First, cement, make a cement, inject inside, then take the other 3 levels. It's the same sitting, by the way, this patient. In 3 hours time, the same single sitting. Although some try to people doing 2 sitting, I do single sitting. And it all depends how much time you take. And this was I always do a myelogram or epidurogram on table just to be sure and have a good night's sleep. And this was post-procedure X-rays. Beautifully, you can see he came after a few years, and this was it, except some epidural vein which is still looking cemented, which is okay. So in such patients, vertebroplasty outweighs conservative management. All the people will talk conservative, but this was a case. You can imagine what really happened, and this is what I presented in Miami World Congress 2012, because it was world record that time. Now people have done even 7 in one go. Now getting into the crux of it, the vertebroplasty or balloon vertebroplasty or kyphoplasty or vertebral augmentation, we know it's a beautiful procedure. I love this procedure, and especially when there is a collapse, you can do a single level, two levels, or sorry, single balloon or two balloons. And I have another technique to this is double balloon kyphoplasty, which I'll explain you. Double balloon, I don't mean this. Double balloon, I mean something different. I'll explain you that. And this is what is there. You put a single balloon, you can go across. I told you in lumbar region is easy. Elevate the end plates, and you look another one like this. You look at the end to end, right to left, and top to bottom. It's nicely elevated. You put your. These are some expendable systems which are there in the market. People can make use of any one of them, which is available to them, or which they can make use of. Be it vesoplasty, be it jack, be it all those coin like things or rings, and all those things are there, and they get expanded to your desire needs. And then you have a vessel plasty also. Initial vessels, there was a problem. It didn't have those holes inside, so it used to be like a ball which used to slide away. So there were accidents because of that, so stop using it. Then they became intelligent. They made few holes in the ball there, so when you inject cement inside, it leaks out through this it interdigitates with the crevices there in the bone, so it used to stay well in there. So this is a nice thing. Lately, they have come with the mesh plastic. They put inside, open up just like the cardiac stents and all. It's like a stent, and you put cement inside those things. They do very well. They're jacks also, as I showed you earlier, and you cement them well. Kyphoplasty differently scores over vertebroplasty as far as kyphotic correction is concerned. People know it. It's a good technique. But in good hands, in early fractures, even cementing vertebroplasty is good enough. So it all depends what kind of fracture morphology there, what is the patient requirement, which level of the spine is the fracture there, is going to have more load coming up, fracture load accordingly. And obviously, you have a more height gain and decreased wedging, obviously, with the kyphoplasty than vertebroplasty. Now I'm talking about some very intricate techniques, the tips and tricks of these, successful techniques. We go inside, always make a trocar and put your balloon there, put it on the right spot, hold it in this spot. If you don't hold this balloon in spot, it does happen. The balloon try to skid in and out. It may skid in, it may skid out, or it may right or left. And sometimes balloon has got a lot of play. It'll go to the area of least resistance, as simple as that. So you may see these shapes coming up, so you have to really, titrate the location of the balloon. And look at this balloon. It has got the double kind of thing, cavitation. It is opening up there. It is dilating here. Can you imagine? And you got a cement. Once you cement inside, you see accordingly, depending on where it is getting the cavity formation. Accordingly, it'll fill the cavity also. And by the way, this patient had few levels gone there. So you have another level. You can see good cement, good kyphon balloon there. And that's where sometimes balloons do burst. So when you're trying to fill in, you're trying to elevate the bony spicules, it may rupture the balloon. It'll again make the bone all black. Simple thing. Wash the thing. Put another balloon if you want to. Otherwise, start putting cement in there. But wash before you do putting your cement, because your cement won't show. Mostly look for cement which is little hard, even which stands out of your injector device, and then you start putting. So you wait till the time. It shouldn't be flowy like this, and then you start injecting inside through those vertebroplasty kyphoplasty needle in there, and you have the fillers there. You go fill inside, and I call it fill it and forget it. As good as that. And you have a fracture void already created by the balloon. Fill that fracture void, interdigitate. I told you again and again, interdigitate by intention, and then that's what it is. There are few cases who either had a osteoporotic fractures or metastatic fractures where there's a cord is already compromised, or putting cement in is a very, very big if, and it can be very risky in routine setting. Today, I'm going to give you a very good technique where I'm doing with very good success in all these patients with the posterior cortical dehiscence, or all these patients. What I do is I put a balloon, translucent balloon through one or two segment below, put it up there, pitch it against the posterior cortex of the fracture vertebra, and splint the posterior cortex there. and save the neural structure from the posterior cortex or the retropulsing fragment, and now put my kyphoplasty balloon inside, inflate the balloons alternatively or together, have a look at the morphology. Now this balloon is the idea is with the dye, it shows me what is happening in the posterior cortex and is any compression indentation coming. And when I elevate my thing, it happens very, very often. If we don't have this balloon, the retropulse fragment will come into the canal, which has happened good number of times in good number of people, although their intent was initially good, but this safety balloon was not there, which is my technique. And I presented in even in South Korea World Congress. This you're seeing beautifully. You're seeing the standing balloon there against posterior cortex. Now I'm elevating. If I didn't have this, I would have not done this case. Obviously, with that amount of cavitation, the things will fall back into the canal, and then you have all this thing. Look at the fracture void created. Look at the straight balloon still in place. Remember, at the end of the procedure, this 6 mm weight, 6 centimeter balloon, you're going to take it out. Sometimes it splints over the 2 vertebral levels. I'll show you in one case. Cement inside, fill it, and just take this out. Do a myelogram, do an epidurogram, be sure. And if it's free flow, then you're not worried. And the patients get a good sleep, you get a good sleep too. And which I told you in the World Congress, I presented in the South Korea. This was the minimally Congress, and that was epidural balloon neuroplasty formalplasty innovation, which I'm using lately more and more in my fracture patients, like 2-level fractures. If I didn't have it, I would have not be able to do this fracture. Simple. Look at the fracture morphology. Look at this retropulse fragments. Can you see this? Can anybody believe this fracture can be cemented? And I'm showing you the well cemented fractures. And this is what is the, you show your efforts, so your words by doing it. And this is before and after you start seeing the fractures there. And look at this. This was the 2-level and the balloon in there. You cement it, take the balloon out, and the fracture void, beautiful fracture void you can see. And patient is happy. Again, one of the loners, old age people, old couple, which are by themselves. You don't want to leave them on bed, because if they come on bed at this age, they're gone. And then it's not only one person gone, the partner also goes away. So please, so this is important. Let's have the realities of life. The happy patient is a happy doctor. There are some potential complications. We know it. They all can be well circumvented with the right frame of mind, right knowledge, right technique, and right skill. So these are important things. Yes, few things which I must detail with my friends is that there can be persistent pain after stabilization. So wait couple of weeks, and sometime a delayed anesthesia could be there. The facet syndrome or SI joint syndrome could be there. And these all are treatable. I do treat these things, and I'm happy that I can treat them so well effectively. So they are my plus points. Then you have costovertebral point tenderness, or I told you the rib head fractures. They can very well be taken care. Like I told you, intercostal neuralgias, you've done it. You are not known the pathology. Reimage in these patients, reimage. Then pedicle fracture could be there initially or by the procedure itself, or they can be new fracture which has come in. They can be recurrent pain after stabilization. This is again you reimage to locate new fracture where exactly is, and after first fracture, what is the rate, what is the frequency? Risk for subsequent fractures is 12.4% is in new fractures, 66% is the adjacent level, and 33% can be distant level. 66% can be within 1 month and 33% within 1 year. Know the facts, treat them. That's what it is. Now, few case scenarios. Again, now it's purely case scenarios now. Theory is totally gone now. That a patient who had this Kummel's osteonecrosis in a ankylosing spondylitis scenario and had a fracture in there, bad fracture, 3-level screws there, 3-level screws here, fracture still painful. We got a bone scan. I did a cementing in this patient, and look at the fracture initially been treated here, and this is what we have done through the small hole. Look at this. We're putting a needle there through these all those bar rods and bars is a little tricky at the dorsal level, but it's doable. Look at this balloon in there and the cementing in there. I'm doing a kind of paravertebral block along with this if pain is there. Patient is able to walk next day or same day. Everybody knows it. And this is a patient who was done a cementoplasty. My friends, all my friends understand there's a small drop of cement which is there. How is it going to help the whole vertebral body which is painful? Look at a small drop of cement. How will it help the whole morphology there? It's going to be painful. It's a failed procedure. It's a cosmetic kyphoplasty. No, either do it right or don't do it. And this is what you do is I put my cement now back in there, and the weight bearing structure is there. Patient is okay. Now back is doctor's mother, by the way. Very recent patient, very recent. 6 level fractures, D4, 9, 11, L1, L2, L4. Look at this. And you don't see the bone at few levels. 1, 2, 3 levels, you don't see the bone at all. And that's where I did a 6 level lately. It's very recently, 6 level, of which the 4 level I did a kyphon, 2 level I did just the cementing. Here I did only cementing, and here I did only cementing. Other levels I did the kyphoplasty, and this is just on table. As soon as I turn the patient straight, and patient is happy. And this is where do a myelogram, the check myelogram, epidurogram. I always do it. This is the upper level. This is the D4 level. By the way, you can see an eye is good, a myelogram going up in there. So this is all clear. D4. I have done till D3 also. I've done cervical, I told you earlier. This is what patient is walking next week. He has a multiple myeloma on treatment with good pain relief. Patient gave his own, testimonials. A recent patient, 6 levels. Now 1 level is up in there, 2, 3, 4 levels fractured, and one is the iliac bone. This is the very big cavitation, another level cavitation on both sides. So I did a 4 level cementing this time. Here is a 4 level cementing, and those 2 levels I did just like bone biopsy. Go inside, or the just go inside, and like we do a bone marrow aspiration, you do a bone marrow injection, the cement injection in there in the cavity part only, and you do a cavity filling, and that is the cementoplasty. A patient who has a vertebra plana, look at this thing, and look at the x-rays now, please. Look at this. This is a fluid cavity. So you look at the x-ray, you don't see this, and this vertebral plana, the kissing disc, you can call it. And look at this. There's no bone at all. Patient was 86 year, was in big pain, cord was getting compressed, he was getting symptomatic, and I asked for fixation. Comorbidities, patient doesn't want, family doesn't want at 86 to be big surgery. And there I came in, and I did a procedure. You look at this, put my needle in there. She's 86, I told you, and we put my balloons up there, inflated the balloon in there, and did my cementing in there. And look at this now. This is the AP view. There's no bone in here. I had done a bone reconstruction. It's like a vertebra remaking or a vertebral reconstruction, not a vertebroplasty. Look, there's no bone in here. Look at the weight bearing structure. And very closely, if you watch it, the flexion deformity which was there, kyphotic deformity which was there, is corrected. Look, there you have anti column now. That's what you're trying to make, anti column reconstruction, which is weight bearing. And patient was back, walking back to home. This is what you want. And another level, patient have a double trouble, fracture and a disc disease, which could be there for ages now. Now patient got a fracture, or patient came for disc problem, and suddenly lately I found one patient came for the disc problem. I scanned it, I found a fracture. So I did both together in one go, and I explain you a little later. And this is how it can be done. You do endo work, you do vertebroplasty. If you're good at both, you can do both. Look at this patient I was saying, old man, very laughing. Look at this post procedure. And PIVD, which was planned for procedure, came on the day with there was some delay in the procedure, and he had a fracture which was painful. This time he had a middle back pain, and he understands this is a fracture pain. So I did a endoscopic discectomy here. I did a cementing up in there, and this is the very next hour. Very jolly, very jovial person. So you want to give them their life back, and that's what that age, and it's a boon. And I told you, in some scenarios when there's semen leak, you can treat with endoscopic work there. Very last few cases now, and this case is there with the acetabular or ischial fracture. You can see, look at the fractures. Look at my friends. He can't sit, he can't walk, he can't stand because of this. And nobody knew what exactly is the nature. So what I did is I put my needle inside, did my biopsy first, and it came out to be a non-Hodgkin's lymphoma. It was not known before. Two people did a biopsy. It was not diagnosed. With my biopsy, it was diagnosed. I went inside, did a kyphon balloon cavitation first. Look at this, friends. And this kyphon balloon is going into that acetabular area. And that's where I did my last filling. The size which can do a patient weight bearing thing. And patient was obviously able to walk back thereafter. And this is a sacroplasty. We get insufficiency fractures, hemangiomas, and you put a needle in there. I put my needle in the fluoro room, take them to the CT room with the needles in place, and do my last of the cementing in the CT room. And so used to do in the fluoro room also. Now I'm doing CT room. So you really know. Sometime you may get cervical fracture. Like this patient had D5, D6 level fracture I showed you. He's one last patient, and this is where we just put your needle there. He had a C2 level. And this is long back, and patient came to my the OPD thereafter. In malignancy scenarios, it is a dorsal D3 level, long back again, 2007, my friends. And I did a cementing of this patient. I was doing for pain management, but it came out to be with a fracture. I did my cementing at D3 level. Look at the 1, 2, 3, D3 level. And these cementings, you do it. If there is a pain, you do a radiofrequency ablation with the RT. Very good response in these patients. These combo treatments are available. I do intrathecal neurolysis in some patients. I'm very good at it, and I found to be very good response with the intrathecal alcohol neurolysis. It's again a very demanding procedure, but very, very effective. Lately, we have a vestibular nerve ablation, which takes the whole pain through the vertebral body. I have done a patient lately with a CA, and look at the CA now here. It is already trying to, infiltrate around. Can you see this? I put my needle in there. This is the plasma. This is, people know it. This is a cannon in the plasma. I put my inside is a angulated one. I can take it in different direction. Put inside. Do my tumor debulking, which I told you earlier. Put my cement in there. At the end of the procedure, in post-procedure room, patients walking comfortably. Yes, pain relief is great, stability is great, quality of life is wonderful if done rightly. And obviously, to conclude, it's a wonderful procedure, safe and effective procedure, and you improve the mobility, quality of life, and you really add value to the patient's life instead of putting them to bed and they may die later on. And well, it's a great procedure which I keep telling, do in a righteous way, and you can always make these things happen. I told you, and in a burst fracture, I told you, in vertebral plana, in multiple fractures, retropulse fractures, and I showed you all in other scenarios. Don't leave them with the fractures and in a paraplegia and in a helpless situation to die. Not fair in these modern scenarios with so many good doctors around. So you're God sent, you do your job well, and count your blessings. These are old people, informed people. You want to give their life back. Otherwise, once they're bed, the whole family gets destroyed, shattered. Yes, keep giving smileys to people who are really suffering all this, and keep them do a right job and give them the smiles back. That's what you are there. And I always say teaching is the best way of learning. I do lot many workshop I've done, and people come from international, people know me well for this, and I love to train right from bottom of my heart, give them best I have with me, my pluses, my minuses, my complication, my positive, energies, and my positive uh, techniques to them, and they are applying them and doing great job back home. I'm very, very happy for that. So at least I'm contributing back, giving back to society in an educational way. And let's keep igniting more minds. These workshops are for that. There was a Miami Declaration which says pain relief is human right. It should not be just a sentence. It should have a meaning. It is not only pain relief is human right from patient point of view. It is our duty to give pain relief. So we are duty bound for that. And that's where, unless you really know your job well, how can you do it? So it has to be effectively done. And we are not doing, friends, just for ourselves. We are doing it for our past generations, for the grandparents, especially fracture, osteoporotic fractures. But understand, we have to leave the world richer with the new technology. And once we grow old, we want a help at hand. Thank you, friends. Thank you so much. Thank you for your time, my friends. Thank you.
Thank you, Professor, for your exceptional lecture. Your experience and insights are truly invaluable for us. Everyone in the audience enjoyed the lecture, and we have the very active chats. I will start reading with the first question. First question came in from the young neurosurgeon in Bulgaria, Edwin Vasvim. He's asking, in order to prevent adjacent level fractures, do you recommend injecting small volume bone cementum? What is your philosophy in this direction? I had many patients who developed adjacent level fractures after injecting maximum amount of safe CC volume, so I tried to inject less now. So this is his first question.
Good question, by the way, and it's a very practical question. People have had a supramaxillary filling, which is more satisfying to the eye, but again, you're having a harder bone, which is more impactful through the adjacent levels, which causing more fracture, at the adjacent level, which is known. So what we're trying to do these days is we are not doing a high fill. We're doing an optimal fill. Don't do a suboptimal fill, because if you leave the fracture cavities, they tend to pain. Sometimes they tend to collapse even the osteoporotic bone is there. But a optimal fill is right, that is required. Which I told you one technique which I use very often is I put radiopaque dye in my cement, which I showed you. Suppose there is a 10 ml cement, I put about 5 ml of radiopaque dye in that. So what happens is over a period of time, this dye keeps getting absorbed. The very cement volume, which was initially 15 ml, reduces to 10 ml. And if it is inside the body, 5 ml reduces to 3 ml. The whole idea is the dye is getting washed away. The cement from the body is into digitating. This is coming inside. So it's not that impactful for the patient. That is important. Impact factor is vital. So adjacent level fractures are taken care by doing an optimal fill. Don't do a overfill, which truly said there was a question, and it is important to understand. Some people have started doing with the calcium phosphate cements, which are less impactful than PMS cements, and they get absorbed with time. They're bioabsorbable. So that way, the adjacent level fracture chances are reduced. So there are few techniques, and if you're already doing a kyphoplasty, you're already taking care that you're not going to overfill it, leak it inside, leak out the cement, then it's one part. But yes, it's important not to overfill to avoid adjacent level fractures. It's very, very important.
Thank you so much for your answer. And another contribution for Dr. Edwin. If the patient develops cystitis after cement injecting, is it safe to conservatively treat the patient with AB only? Or you would advise to do open surgery and try to remove the bone cement, theory of the glycocalyx production from the bacteria, so they cannot be treated safely with AB only?
Now, once again, I want to hear your question again, and I didn't get the question again. If you please repeat it.
Oh, okay. So if the patient develops discitis,
Okay, I get you now. Discitis. See, if your semen leaks into the distal level disc, which happens many a time when the end plates are fractured, and it may be diagnosed or undiagnosed, inadvertent, you're putting semen inside the vertebral body, it gets into the discal area. Rarely it causes discitis, number one, because these cement, which PMS cement, they are thermal. They're thermal cement. They cause a lot of 90-degree and all. So they're already sterilizing one way or the other. Second is, what all procedure you're doing. You don't expect any infection during the whole vertebroplasty procedure. The vertebroplasty or vertebral augmentation is a pure aseptic procedure. You don't expect that any of time when you do a cementing, there's going to be some infection there, and which can cause the bone infection, the very vertebra getting infected. You don't want that to happen at all. So you take all precautions possible. What I do in my cases, good you brought this point, is the same cement where I'm putting my dye about 5 ml, I put about half ml of antibiotic also. Or you can either use an antibiotic cement, which is available in the market. But here what I do is I've got a patient IV antibiotics. So I use the same IV antibiotics, put half or 1 ml of IV antibiotic in the same cement which I'm mixing, same cement. Now this cement is now antibiotic dye-laden cement, where the dye will wash over the time, antibiotic will take care because it's mixed with the cement, it'll take care of the infection part. So discitis can be a question if you're not very careful in the cement part, which I don't expect that if infection goes into the vertebral body, this can be a bigger problem than a discitis. Discitis you can treat with endoscopic work. You do endoscopic discectomy, endoscopic clearance, endoscopic lavage or debridement, you can do it. But what to do with the vertebral body cementing if it gets infected? You can't remove the cement now. It's already fixed in there. So it's all the more important to be as aseptic as possible with all precautions. So I have not seen any kind of infection in my cases. Right from day one, I started putting cement. Initially, I used to use antibiotic cement, but lately I'm putting antibiotic in the mixture. So I've not found any infection. And you obviously have to be very, very careful as far as infection is concerned. And you always give a week of antibiotic. I always, in all my patients with a high procedure, be it endoscopic discectomy or vertebral augmentation, I gave about a week of IV antibiotics, or 1 or 2 days of IV antibiotic in patients in the hospital, and then oral antibiotic for about total a week time, and at least 2 antibiotics. So once it's taken care of, there's no chance of infection. Be very, very careful, and it doesn't happen. I understand question is logical. If it leaks into the disc, if there's discitis, what? Discitis, there could be some reason of a chemical discitis. Let me make you understand. PMA and cement liquid can have a chemical irritation. So those chemical discitis could be known, but it's not infected discitis which is there. There can be some spasm, some pain in some patients with the cement leakage into disc, which can be just like a disc pain. You don't have to worry. Manage it, treat it, give some analgesic, give some, all those little narcotic like Ultraset or all those medicine, tramadol, Ultraset combinations, and they're taken care of, very well taken care of.
Thank you so much, Professor. Another question also from Bulgaria. What is your strategy in patients who develop many adjacent level osteoporotic fractures with retropulsion of bone fragment with neurologic deficit? Should we try to pedicle screw with high risk of adjacent level fractures and PJK, or we should do bone cement and decompression?
Very, very good question. Like depending upon so many things, what is the patient age, what is the bone health, what is the patient's requirement, what is the patient work level, all those things, they come and they count in the whole scenario. When you have an overall picture ready with you, then depending on with a person like me who was doing so many multiple level fractures, even retrobus fracture, posterior dehiscence fractures, burst fractures, with my epidural balloon, safety balloon, I do cement them well, and I found to be a very good results. You can do your bracing, you can do your all those osteoporotic medication and all that is there for a complete healing and cure. But when there's a neurological compromise which is there already, depending upon if you think this neurological compromise is just one of the spinal shock, and you give a steroid and is already reversing and is getting better with time, and you don't have any fragment which is lying in the canal or any compression which is there or any imminent further aggravation of the compression, or there's a free fragment which may fall into the canal after by any movement of the part of the patient. And it's already said many times, these all accidents, spinal accidents, they happen when the patient is transmoted in the triage. Patient has fallen from the height, from a tree or whatsoever accident, and they bring the patient in the lab with the folded thing. Once they fold the patient in there, the retrobus fragment gets into the cord, canal, and causes more problems. So mostly because of this. So it's very, very important to educate the masses that once such an accident has happened, patient should come very flat on a flat surface, and not to put on a bed sheet or something and bring folded, so that causes damage. Now again, coming to the point, when the patient is with us already, there is some damage. If it's reversing, you always give a conservative management a first go in such patients. And if not, then urgent decompression is the answer. Urgent decompression of the canal and put a screw fixation obviously is the only answer for such patients. So this horse has to be titrated. Studies of all sort, and MRI and CT and X-ray, everything is to be done. Clinical examination is very, very vital. And as I told you, in my cases, if I think it's already reversed and I have a patient whom I can cement well, I would love to cement, and my the spinal cord is taken care conservatively. But if you think there's a definitely a compression which is mechanical in nature, which needs a surgical decompression, must decompress and proceed with your fixation part. Must.
Next question from Edwin Vasfi. What is your advice in treating metastatic pathological fractures in thoracical level, which has compression to the spinal cord but without neurological deficit? Is it safe just to inject bone cement, or you would advise to do what you would advise to do and open laminectomy with prophylactic purpose?
Good question. I think it all depends what kind of metastasis is this, what kind of tumor is this, what is the tumor type, subtype, what is the prognosis on the tumor initially, if it is like multiple myeloma which is treatable, so we take its own right. But if it's something which is progressive, it's going to increase in its size, increase its compression and all, then it's more important to decompress the laminectomy and decompress, because there's going to be increased incremental compression coming up onto the cord, and neurological damage is going to be there. But if it is like a multiple myeloma, which is reversing, which is getting corrected, which is getting cured, and there is a osteoporotic cavitation which is there, which is pressing to the cord to some extent, and without any neurological deficit, which you just mentioned, It's easy to cement these patients, and you have to maintain the vertebral body height, and be it kyphoplasty, be it a vertebroplasty, depending on patient to patient, and technique and your skills. And definitely in my cases, where I do very often, I told you, I put my epidural balloons, posterior cortex, split my posterior cortex, do my cementing inside. And once my cement is done well, I just take the balloon out, 6 mm balloon back to the spinal canal. So cord is happy, patient is happy, I'm happy. So that way, these are few techniques which is there. But when you do this technique, always remember, you don't have to do through single needle only. You can try 2 needles, put some volume, small volumes from both sides. So better reinforcement with the smaller volumes instead of big volume, which may leak out. Never ever let the tumor get pushed back into the canal because of your procedure. Then you are the cause of the problem, not the tumor. So this is to be taken care. A good radiological study will really tell you everything. A CT is always of help to know the bone morphology, which I do very often in all my cementing patients. I tend to do a cementing, the CT as well as the MRI and X-ray all, and then take the patient up. Definitely, if the answer is, if it is doable, cementing is the best option. Incurable disease, in incurable disease where it's going to be increased incremental pressure, you can go for laminectomy and fixation and decompression. But again, one point, remember, if patient is incurable, progressive disease, then it's more of a palliative procedure. So many patients won't be happy getting a bigger surgery done, like laminectomy or decompression, for want of decompression where there is no neurological deficit already. So why would a patient go for a big surgical correction when there is no neurological deficit and the prognosis is poor as it is? Tumor prognosis is poor, patient prognosis is poor. So one has to really calculate what is the prognosis, what is the tumor type, what is the tumor treatment, what is the longevity of life, and what much is the requirement. So accordingly, one would go for surgical correction. People normally would avoid.
Thank you so much, Professor. And the last question from neurosurgeon Edwin Vansui, Bulgaria. Some patients have a lot of adjacent level osteoporotic fractures. Is it safe to do 5 or 6 level vertebroplasty, or is it better to just treat the osteoporosis and prevent PJK from vertebroplasty?
A good question, very good question. See, I told you, even if single fracture, osteoporotic fracture, I cement, even a single one, I treat all other bones to avoid any future fracture. So I treat osteoporosis very aggressively if I get a one patient who is osteoporotic cavitation and fracture which coming up. So that's statement number one, very vital. Now coming to the other part is, if there are adjacent level osteoporosis, severe osteoporosis, you don't have to cement them all. You cement only the one which is fractured already. You have this the CT and other things and scans and everything. Yeah, the MRI may tell if there's a bony edema coming at the adjacent level, which is not evident X-ray wise. Then you can think of putting in a cement in there. I've done prophylactic vertebroplasty initially in my career when teriparatide, denosumab, other drugs were not there. Now these are very good medication which are already there, and calcitonin nasal sprays. So you can try with them. If patient develops another fracture anytime, you can always take the patient into the OT, put a needle in there, and cement that new fractures also. So there's no worry as far as there. Yes, don't leave the symptomatic, painful osteoporotic fractures in the body of the patient, which is to be treated with painkillers. You want to avoid that. And with the osteoporosis of aggressively treated, most of them tend to get better with time. It is seen lately now, many people, even in osteoporotic fractures, which are already there, people treat them conservatively with the bracing and with all this anti-osteoporotic medication for the want of or visual thinking of a cure or healing or spontaneous correction, which does happen, not in very osteoporotic people who had some traumatic fracture, some osteoporosis. There it is reversible, then it corrects by itself, then it's cured. Otherwise, in severe osteoporotic, pathological osteoporosis, you don't expect a spontaneous healing, and there are chances when you're trying to do conservative management, there can be further collapse, there can be neurological deficit, damage, or consequential damage which may come up. So if I leave a patient, like I told you, a patient who had a 6-level fracture on conservative management, I'm very watchful of those patients that there's no increased problem as far as fracture level is concerned, or adjacent levels are there. Like he had a 6-level fracture from one level because he was left alone. So this is a complacency and part of the surgeon and patient and definitely caregiver.
Thank you very much. Next question from neurosurgeon, Turkey, İzmir, Ertan Sevil. Thank you very much for this excellent presentation. There is something I'm curious about. I sometimes perform vertebroplasty unilaterally, especially the compound TH12. What do you recommend for regions such as L1, single, and bilateral? Single or bilateral? Yeah.
I understand. L1, when you have a wider pedicle, you know, as far as CTMR is concerned, you can really see this wider pedicles. What I do is all my patients, when I do my cementing, when the scans are done, I go to the scan room. I go to the scan room, I sit with the scan person, radiologist, draw my lines in the scan room itself. When the images are being done, the imaging has been done, scans have been taken. And once I am satisfied that I can take my needle through, like in endoscopy discectomy, same I do. I can take my needle, I look at my port and where I have to start line and end line. When it meets without breaching the medial border of the pedicle, I try to do with the single needle technique, number one. Number two is that single technique, when you're trying to avoid medial border of the pedicle, sometimes you don't really worry about the lateral border of the pedicle. You can go parapedicular also. So that way, when you go more laterally, you can be more oblique and cross with the single needle, go across and put a cement side. You don't worry if you go parapedicular unless you're hitting the nerve there, exiting nerve, which you don't always. It's a safe technique. So you go inside, and this all is pre-thought, pre-planned. It's like a war. You prepare yourself for the war, and war is very short-lived, but preparation is long. So this, but cementing procedure is like a war scenario. You get only half an hour to work inside the OT for a single level. If it's multi-level, is a different thing. But then again, your preparation has to go in mind, and it comes with a lot of experience. For me, it's like a cakewalk. I take my patient in there, put my needle in there, put cement in there, and let the patient walk out of the OT. This is my thing. But I always say never ever be complacent. I've had my own share of problems because of complacency, overconfidence. So this is important, that this procedure is very vital, very good procedure, very rewarding procedure, but in a righteous way. This is something which I always, ask people, my friends, don't leave your patient in pain. It's such a good procedure. Do it effectively, relieve it. You'll a lot of blessings from the patient. And as I told you, your godsend, you are to do your job well. And this is my recommendation. Now, again, coming to the point, T1 level is easy. The pedicles can still be oblique. In dorsal level, mid dorsal level, pedicles are very, very straight. You have to do two levels, or you have to go parapedicular, like costotransverse parapedicular. You have to go in there and you can plan your things. In most of the cases lately, be it kypho, be it vertebroplasty, I put single needle first, as oblique as possible. And again, you have to look at the fracture morphology. Fracture is more on your side or other side, contralateral side. Fracture morphology. Put my needle in there. I'm a right-handed person. I do mostly from the left side, but it can be other side if need be, on the right side of the patient. So you go in there and you start cementing. Once your cement looks adequate, Phil, with the single needle, you don't have to put a second needle in there. But if you have any doubts, your fill is not great enough, you take a second needle from the other side now and go to the area where you don't see the cement. You see a rarefied bone there. You don't see the cement in there, and you just put your cement in there. Now it's good. Now for these second needle in place, you have to make a fresh cement because your first cement is already washed over. So always keep two bowls, kind of ball cement mixing bowls, and sometimes take cement half and half. Another time I keep two cements ready. So make one cement like 6 level. Levels I do with single cement, 3 levels are with the second cement. If it is just one level at two needles, I take half and half because I don't need volume now. I need fresh cement in a fresh cold saline. So cold saline is very, very helpful, and dye and antibiotic, and I told you all those techniques which is coming to my way.
Uh, Thank you very much. Now, Dr. Mehmet Secher from Alanya is asking, did you have any spondylodisticities after vertebral augmentation? What is your algorithm for these patients?
Good question again. It has come up again. As I mentioned you earlier, luckily in my about 800 of vertebroplasty and kyphoplasties, I have not had a single level discitis yet. And as I told you, right from my first vertebroplasty, I was using antibiotic. I was trying to be as secure, as safe possible, the antibiotic. And second is I try to avoid semen leak into the discal space. Although sometimes there is a end plate dehiscence, you can't really avoid. Cement is going to go in there in the discal space. I'm usually not worried because PMS cement gets heated and it kind of kills the bacteria around, and you don't bring a new bacteria in there because the disc, as it is inert or sterile area, and you're putting now a sterile solution inside, so there are less chances of discitis until there is a chemical discitis, which can be because of the polymethyl methacrylate liquid polymer which is there, that can cause irritation and discitis. I've had patient whom I was doing a vertebroplasty or kyphoplasty along with endoscopic work, and there was an end plate dehiscence, so cement leaked into the canal. So I was doing endoscopic work, and I could see the cement coming into the disc. I could remove the cement easily. So those are different things. Yes, pulmonary discitis should not happen. If it has happened, if you know the endoscopic job well, you can do debride, do the things well. Cement is not the culprit. Is this bacteria going with the cement is the culprit? So please, please, again and again, I'm reiterating, be as sterile as possible with the cement, with the solution making, with the environment, with the injection techniques, and obviously mixing antibiotics into the cement, which I always do it in all my cements till date, which I put the antibiotic inside the cement mixture, and along with the dye. I told you for last 10 years or more, I'm already putting dye to make it more radiopaque, because radiopaque cement was not all that available in those times. Now we have a barium sulfate, which is 20%, which is there, and other cements, which is very good. Radiopaque cements are there. So you don't have to put dye then. But I always put antibiotic in the cement mixture and put inside. Never had an spondylolischitis. The day I'll have it, I'll treat it because I do endoscopic work. I do get discitis in those patients. I do percutaneous disc procedures, so many of them. Lately, I'm doing a PRP and other things in the disc. There are chances of a discitis. Luckily, if you have a sterility and you have a good antiseptic precautions, rarely you get this discitis. If you get it, you have to treat like any other discitis for the matter. There's no special treatment required for that.
Thank you very much. And now we have contribution from Dr. Nurullah Kozmene from İzmir. Thank you, Professor. It was a great lecture. All questions I had been asked. Thank you again. Another thank you, Professor, for a good lecture from Dr. Ramazan Özdemir, İzmir. And the last, Edwin Vasily from Bulgaria, thanks you for your patiently answering his questions. Thank you for sharing with us all of your experience, compassion, and knowledge. And I would join with his words of gratitude. Thank you, Professor, very much for this amazing lecture. If anyone in the audience has a contribution,
it was absolutely my pleasure to share my work, and you could take this much, Miss, I squeezed my lecture in there in 1 hour time. I told Professor beforehand, Dr. Hassan, Professor Hassan, I'll take about an hour because there's so much to share, so much to talk, and look at my spirit. I want to give as much I can. I know it all depends the absorption power of the people who are listening, and because this is very close to my heart, I can talk for hours together, but all depends how much one can absorb. It should be relevant also, so I try to be as relevant as possible, as short as possible. Still, it was 1 hour thing, but I wanted to give you such a variation in the technique, and such a novel technology which is there, and with all those things coming up, and probably you can do justice to your patients. I'll feel all the more happy with all that. Thank you, my friends. Thank you for allowing me to talk at length and talk at leisure. Thank you so much, my friends. It was pleasure, absolute pleasure of mine.
Thank you so much, Professor. Kamil Hoca, do you have any contributions or any?
No, it was a wonderful lecture. I want to thank again.
Thank you. Thank you, friends.
I want to thank everyone who joined today. Thank you so much.
Pleasure.
Thank you, Professor. Thank you, audience, for your contributions.
Thank you. Bye-bye. Bye-bye. Pleasure.
Thank you.
Selin.